Good morning. I'm Professor Andy Bush from Imperial College. I'd like to thank the organisers for inviting me to do this Meet the Professor session. I'm very sorry I can't be with you in person for reasons outside my control. You can see my email address. Do please email me if you have any questions. I hope I shall be able to join over the internet so that we can have a discussion. So I've been tasked with talking about kids, difficult asthma and fungus. I have no conflicts of interest. The aims of my talk are as follows. I'm going to propose a paediatric definition of severe asthma with fungal sensitization. It's based on the adult definition but different from it, as you will see. I'm going to discuss the clinical features of severe asthma with fungal sensitization from our Brompton Paediatric series, I think the largest series to be investigated bronchoscopically. I'm going to review treatment data. I'm not going to review papers in which ABPA and SAFS are combined because we simply don't see allergic bronchopulmonary aspergillosis in children with asthma, or at least I don't. But I will review the treatment data and show how it might apply to children. I'm going to review potential mechanisms and hence potential future treatments. This is going to be a paediatric, not an adult-focused talk. I obviously have to draw on adult data because there's much more of it than there is in children, but I do not treat adult patients. So this is a simple model for a simple paediatrician. That's Aspergillus fumigatus. There are two mechanisms whereby disease are caused. The first is the release of tissue-damaging enzymes. The second is by the stimulation of an allergic response. There are two modes of treatment. One is to reduce the burden of fungus, which will have good effects on both, at least theoretically. And the other is anti-inflammatory medications to reduce the allergic response. So what does SAFS look like in children? Let's start first of all with the adult definition. This definition is therapy with high-dose asthma medications, 500 micrograms of fluticasone a day, or continuous oral steroids, or 4 prednisolone bursts in a year, or 6 in 2 years, and an IgE less than 1,000, and negative IgG precipitants to Aspergillus fumigatus. This is because the adult doctors who see ABPA with asthma do not want to confuse the two diagnoses. The other requirement is sensitization, either a positive skin prick test more than 3 millimeters or a RAS positive greater than 0.4 to at least one of the following fungi: Aspergillus, Cladosporium, Penicillium, Candida, Trichophyton, Alternaria. What about children? How should we adapt the definition for them? Well, my proposed diagnostic criteria, and I hope we'll be able to discuss this, are severe therapy-resistant asthma with any pattern of symptoms, either an exacerbating phenotype or chronic symptoms. They need to be sensitized to at least one fungus as defined by adult criteria. We do not have IgE or IgG criteria because ABPA is rare to non-existent in children with asthma. Quite common in children with cystic fibrosis, hardly ever, if ever, seen in asthma. Management overview before we get down to details. Minimize fungal exposure, so avoid mould in the house. Unfortunately, reports often exaggerated to try to bolster claims for rehousing. Prevent the child going into stables to muck out horses, and check any nebulizer is not contaminated with fungus, although of course the use of nebulizers at home in children is now vanishingly small. We would sometimes use oral azoles, and it's important to remember that itraconazole has an interaction with inhaled steroids at the cytochrome P450 level, and whereby the effect of inhaled steroids is amplified and Cushing's syndrome can result. And we've also sometimes used nebulized amphotericin. So clinically, what does SAFS look like in children? So we studied 82 children with a median age of 11.7 years with severe therapy-resistant asthma. 38 of these patients had SAFS, leaving 44 who did not, and the SAFS patients were defined by a specific IgE or skin prick test positive to Aspergillus, Alternaria or Cladosporium, and they all underwent bronchoscopic evaluation. The children with SAFS had earlier onset of symptoms, 0.5 versus 1.5 years. They had a higher IgE, 637 versus 177, and more sensitization to non-fungal inhalant allergens. They were more likely to be prescribed maintenance oral corticosteroids, and indeed 42% of them were having oral steroids. I should stress this was in the era before mepolizumab was available for these children. Airway inflammation and remodeling were the same in both groups, and 8 out of 10 of the SAFS patients versus 11 out of 18 of the STRA patients who were trialled on omalizumab responded. So what do we know about treatment options? And these data are largely from adult studies. This first randomized controlled trial used the standard definition of severe asthma with fungal sensitization, as I've put up. They had to be sensitized to at least one allergen, a fungal allergen with IgE less than 1,000 and negative IgG. They were randomized to oral itraconazole or placebo for 32 weeks and were followed up for 16 weeks. The endpoint was AQLQ. Rhinitis score, total IgE and respiratory function were also studied. 58 adult patients were enrolled. This first panel shows that the AQLQ score, the solid grey line is those treated with the itraconazole, the dotted line placebo, and you can see there is a significant improvement over the 32 weeks of treatment in AQL score, but once they stop the treatment, the improvement disappears. If you look at the rhinitis score, again you can see there's some improvement in the rhinitis score, but this is very transient, and once the treatment is stopped at follow-up, they lose the benefit. So summarizing them, the AQLQ and rhinitis scores improved, morning peak flow increased, total IgE dropped by the quite significant amount of 510 versus an increase in 30 in the placebo group. There were side effects, 7 in the itraconazole group and 2 placebo patients discontinued treatment. And 60% of the SAFS patients had a very large quality of life improvement with itraconazole. Another randomized controlled trial, this group used voriconazole. They treated 56 adults with SAFS with 3 months of voriconazole, and they chose voriconazole because it does not increase steroid bioavailability. There was a 9-month follow-up period. The inclusion criteria included the need for having at least 2 severe attacks requiring 3 days or more of oral corticosteroids in the previous year. They were sensitized to Aspergillus, voriconazole levels were monitored, and the primary endpoints were quality of life and asthma attacks. Here you can see the asthma attacks, and you do not have to be a statistician to see that there is absolutely no difference between the two groups. And again, asthma-related quality of life, you don't have to be a statistician to see there's absolutely no difference. This was a negative study. The next paper I'd like to present to you is a retrospective study of 41 patients. They were treated with any one of a number of antifungals, terbinafine, fluconazole, itraconazole, voriconazole or posaconazole, plus standard asthma treatment, and they were compared to 9 patients who just had standard asthma treatment. And retrospectively, this group found that antifungals improved ACT, peak flow, and IgE. and they had better response with longer periods of treatment, and it was well tolerated. I should stress this is not a randomized controlled trial. Treatment length was at the discretion of the clinician. And you can see here in this panel the relapse-free rate at 6 months of follow-up, and you can see with 12 weeks to a year's treatment in 8 patients, they did rather better than those who only had 4 to 8 weeks treatment, that's the dotted line. And relapse on discontinuing therapy was quite common. What about the acute asthma? I could find only one case report, and I have to say I would not recommend this antifungals as a treatment for acute asthma unless you thought there was an active ongoing fungal infection. This was a case report of an 83-year-old woman who had a 33-year history of asthma on corticosteroids, both oral and inhaled. She had a poor response of acute wheeze to oral corticosteroids and antibiotics. She was found to have positive Aspergillus specific IgE and IgG, a positive galactomannan test, and positive Aspergillus fumigatus in the sputum. They added voriconazole to her treatment, and you can see the results here. The voriconazole, you can see at the bottom, was added at about day 13, after which her wheeze disappeared and her betamethasone dose could be reduced. Whether this is coincidence or not, you simply cannot judge from this case report. And it is possible that this is in fact treating acute Aspergillus fumigatus bronchitis in an adult who'd been immunosuppressed. So, summarizing the various treatment options, the data are very sparse and scratchy. It's very difficult to make a coherent case that antifungals work. Anecdotally, I have tried them, sometimes with apparent great success, but the data are that we need more data. We need really good randomized controlled trials in these patients. So what do we know about potential mechanisms of severe asthma with fungal sensitization? And the first clue of the importance was from this study, this bronchoscopic study. I've shown you the clinical data, and you can see in the left-hand panel BAL IL-33 in patients with So what about IL-33? So this is Professor Sejal Saglani's data. She looked at neonatal mice. She looked at sensitization of neonatal mice by an inhalational challenge, no intraperitoneal systemic sensitization, looking at alternaria versus house dust mite. The airway responsiveness was the same, but there was worse inflammation with alternaria. So in this panel you can see the saline controls, house dust mite and alternaria, and you can see that total IgE is much greater in the alternaria challenged mice. If you look at total lung inflammation, you can see that the alternaria challenged mice were more inflamed than the house dust mite challenged mice, and both were more inflamed than controls. And in BAL eosinophilia was worse in the alternaria challenged mice versus house dust mite. Both were much worse than the phosphate buffered saline control. What else did Professor Saglani find? Well, IL-4, IL-5 to IL-13 were all the same. If you look here at IL-33 in the lavage, you can see that the alternaria mice have more IL-33 than house dust mite. MMP9 is also elevated more in the alternaria challenged mice. There are more IL-13 positive innate lymphoid cells in the alternaria challenged mice, and more IL-13 positive T cells. So there certainly seems to be accumulating evidence that in this murine model that there's something special about alternaria. It causes more inflammation than just house dust mite. So should we be interested in IL-33? Well, this is a GWAS. You can see in this Manhattan plot that the IL-33 comes up very strongly. There are other culprits you'd expect, ORMDAL3/GSDMB locus, but IL-33 is giving a signal. What is IL-33? Well, it's an epithelial alarmin. It's part of the innate immune system, and it's released from epithelial and smooth muscle cells, and it's implicated in causing inflammation in adults, and it binds to the ST2 receptor. Here you can see in this scheme of things the bronchial epithelium, which is the first receiving point for allergens, pollution and infection, signals systemically through IL-33, IL-25 and TSLP, probably through innate helper cells, and through the innate helper cells a type 2 inflammatory response, airway remodeling and differentiation into type 2 cells. And the innate helper cell seems very key in that, and the bronchial epithelium a key player in driving it. We also found that IL-33 is expressed in severe asthma. These are our endobronchial biopsies. Disease controls panels C and E, panels D and F severe asthma, and you can see the brown staining both in the epithelium and submucosa in children with severe asthma. It appears possible that it's an important mediator in pediatric asthma, and it appears to be steroid non-responsive, unlike the standard Th2 cytokines. And we speculate that IL-33 could be a novel therapeutic target in STRA. Now, I have to stress to you, of course, this is a cross-sectional study, this is observational, we still need more data, and this is still speculative. So further mouse work. So Professor Saglani looked at mice who had the ST2 receptor, the IL-33 receptor knocked out, and the alternaria challenged mice, if the receptor was knocked out, there was less airway responsiveness and inflammation. So looking at panel B, the left is wild type, the ST2 knockouts are on the right. The wild type challenged with alternaria, as you would expect, they had more airway responsiveness, but this was partially reduced in the ST2 knockout mice. This shows the total IgE. Again, on the left, as you've seen before, alternaria challenge leads to an increase in IgE, but if you knock out the ST2 receptor, this response is lost. Again, looking at IL-13 positive innate lymphoid cells, the standard result you'd expect on the left with alternaria challenged mice, wild type mice. The ST2 knockout mice, you do not see this enhancement of innate lymphoid cells. T cells were also reduced in this model. And alternaria effects appeared to be partially or totally steroid resistance. Airway hyperresponsiveness driven by alternaria was unaffected by steroids, and inflammation was only partially steroid responsive. Total lung inflammation, but not BAL inflammation, was steroid responsive. So here in this panel you can see a methacholine challenge in these mice. You can see with increasing doses of methacholine, the phosphate buffered saline challenged mice and the alternaria challenged mice, and you can see that that alternaria with budesonide, it made absolutely no difference to the reactivity of the airways. Here, if you look at BAL inflammation with budesonide, there is reading from the left, phosphate buffered saline, no inflammation. Alternaria and house dust mite with PBS treatment, there is more inflammation with alternaria. If you treat with budesonide, there is still some inflammation in the alternaria mice, not in the house dust mite mice. Now if you look at total IgE, little change with pure saline challenges. Alternaria, much more IgE, and if you try to abrogate that with phosphate buffered saline, it doesn't work. But on the far right you can see there is still persistent inflammation even in the budesonide treated mice. IL-33 is steroid resistance, and steroid did not reduce lung IL-13 nor IL-13 positive innate lymphoid cells nor T cells in the presence of alternaria. So here you can see lung IL-33. Again, if you look at the alternaria treated mice, in the absence of steroids, a lot of IL-33 cells, but they're still seeing IL-33 cells even with budesonide treatment. Here again, innate lymphoid cells. The first was lung IL-33. This is innate lymphoid cells, and you can see that budesonide reduces the amount of inflammation with house dust mite, has little effect on alternaria induced. Same with IL-13 T cells. You still see some evidence of IL-13 positive T cells despite steroid treatment, and same with lung IL-13. Budesonide does not seem to be able to abrogate the changes of alternaria, whereas it clearly does with house dust mite. We also did some work on cultured fibroblasts from the pediatric airway biopsies. IL-33 stimulated collagen secretion from cultured airway fibroblasts, and it was steroid non-responsive. So here you can see the control collagen secretion. IL-33 next stimulates it. Budesonide on its own, no effect on collagen. Budesonide and IL-33 collagen synthesis continues. And airway fibroblasts also express ST2, the IL-33 receptor. So where does this leave us? There are data implicating the epithelial alarmin IL-33 in severe therapy-resistant asthma and SAFS. I should emphasize these patients are already on high-dose steroids, which may well have had an effect on type 2 inflammation. The IL-33 effects appear to be modulated through the ST2 receptor. And severe asthma with fungal sensitization, at least related to alternaria in a murine model, may be IL-33 mediated and steroid resistance. And we need novel strategies. Perhaps an anti-IL-33 monoclonal will come on the market, or an ST2 blocker. Perhaps we need other anti-type 2 approaches, such as amlizumab and mepolizumab. And seeing the MMP9 elevation at least raises an alarm bell. Do we need anti-neutrophilic strategies? There is a suggestion that reducing fungal burden may be beneficial. Alternaria alone seems to affect steroid responsiveness. So what are my take-home messages from this talk? The first is we must optimize standard treatment. Most SAFS treatment trials are from the pre-biological age, and we need a new trial to find out whether in fact things like MEPO are preferable to antifungals. A trial of antifungals such as posaconazole or voriconazole is in my view legitimate in treatment meeting criteria for SAFS who are uncontrolled on standard therapy, but you should stop if there is no benefit. One for the future may be IL-33 monoclonals, which could possibly be used. So I finish with a picture of my 6 grandchildren. Thank you very much indeed for listening. I hope this talk has been of some value, and I